We go ahead and get started here. And we've got a lot of interesting cases this morning, a lot of neoplasms today. And so give you guys a chance to hone your neoplastic pathology skills a little bit here. All right. Anybody want to start off with this one?
Good morning. I can take this one. So this looks like maybe a shave of a pedunculated lesion or maybe an enucleation.
Yeah,
Um,
I think you're right. I think it probably was sort of sitting up like a little knob on the skin. And they just decided to decapitate it there. It's kind of
mhm.
interesting because these lesions usually are not this way. They're usually kind of deep to the skin. So this was kind of funny that it was sort of elevated like that.
And it looks neoplastic.
Okay, good.
I think it's pretty well demarcated and the shape is symmetric, although the stroma looks a little bit more disorganized. But overall, I feel like it looks benign.
Yeah, exactly. Low magnification, pretty much symmetrical, well circumscribed. Um, it not just tiny, but it's not gargantuan. So relatively small, well circumscribed, symmetrical. All the three major uh, criteria for benignity at low magnification. Now, obviously, we can go to higher magnification, we may change our mind, but at least at low magnification, I totally agree. It looks benign. So, do you think this is an epithelial or non-epithelial lesion?
From low power, I'm thinking non-epithelial.
Yeah, good. I mean, you don't see anything that looks like obvious epithelium. You don't see anything that looks like an adnexal structure. You don't
Mhm.
see cells that are closely opposed to one another. It's got kind of just a very pale, maybe loose mucinous stroma, and then some cells in the background that maybe they're spindle. It's hard to be certain. Good. So I agree with you. It looks like a benign neoplasm, non-epithelial. And we say non-epithelial in your level and our level. What three main differentiations are we thinking about primarily?
Um, I guess it would be like adnexal structures
Well,
or
adnexal structures are a type of epithelium. Um, but when you think about non-epithelial structures, non-epithelial differentiation, there's really three main ones that I want you to hone in on. There are lots of things that can be non-epithelial that, are in the world of pathology, but in the world of dermatopathology, in the world of passing your board dermatopathology, there's really only about three that you need to focus on, which is good because I don't want you to just go down a huge rabbit hole of, oh my goodness, there's like a gazillion things that can give you non-epithelial differentiation with spindle cell morphology and yada, yada, yada. I don't want you to get too far down that in the weeds there. So
Mhm.
when you're just looking at something, say non-epithelial, I sort of want you to have a reflex arc to think about three main types of differentiation.
Okay, maybe um neural, um muscular,
Good. And then there's one more.
maybe is follicular one.
No, that's another adnexal one. But the last one is fibrohistiocytic. So those are the three main spindle cell lesions that you're going to encounter in dermatopathology. Now there are others, like I mentioned, but those are the three major ones. Those are the ones I want you to focus on. So when you see something like this and you say, this looks non-epithelial, I want you to ask yourself, is it going to be neural? Is it going to be smooth muscle and not skeletal muscle? We hardly ever see skeletal muscle lesions in dermatopathology. And then the
Mhm.
last would be fibrohistiocytic. So when you see those, you're going to say, okay, it's going to be one of those three most likely. So I need to ask myself, how am I going to tell those apart when you go to higher magnification? So we are going to go to higher magnification now. And which of those three do you think we're dealing with here?
I think more neural.
Yeah, it is more neural. Why? Why did you say neural and not say one of the other two?
Um, I I guess it looks more like nerve cells, the spindle cells. They're more comma shaped.
Okay, well, you got to know why they look like nerve cells. So, you're going to look at it and say, what's the morphology of a cell that has a nerve uh, characteristic? And generally, what they have are these sort of delicate, sort of S-shaped nuclei, like you see here. They often have a fibromucinous stroma. You see all this mucin in here?
Yes.
Very characteristic of neural neoplasms. Not all of them, so like a neuroma, for example, won't have that much of a fibromucinous stroma. But if you see the fibromucinous stroma that favors, or just mucinous stroma that favors neural, and of course, whenever you see mucin in a neoplasm, what other kind of cell will you often see floating in that mucinous stroma? Like maybe that, possibly, or see if I can find.
Mast,
I think you said it. Yeah, say it again.
mast cells.
Yeah, mast cells. Good. Mast cells love mucin. Whenever you get some, like an abundant mucin in a neural neoplasm, you almost always see mast cells. And so when you ever do a shave biopsy, say of a neurofibroma, for example, a lot of times they bleed more than if you do a shave biopsy, say of maybe a dermatofibroma or something like that, because the mast cells release heparin and then that bleeds a little bit more. So that's
Mhm.
the reason for that. So you think this is more likely to be neural? Good. If it were muscle, what do those nuclei look like in a muscle neoplasm?
I think more like a cigar, like
Yeah, good, good. They're
rectangle.
more kind of blunt. They look like a cigar. They don't really look like they're sort of fish swimming nice and lazily through this nice sort of sea of fibromucinous stroma here. And then the last one are the fibroblast and histiocytes. What do they tend to look like?
Um, Foamy, maybe more foamy.
They can be foamy. Sometimes they can be. Yes, they can. But usually they're a little bit more sharply angulated. And you get histiocytes that they almost look like they have little sort of spikes at the periphery sometimes. If you see like say a fibrohistiocytic cell in a dermatofibroma or an atypical fibroxanthoma, they look more, uh, they're sort of like sharp angles as opposed to being cigars or blunt or blend-ended nuclei or cells that are kind of this delicate S-shaped nuclei. So they look a little bit different. Each one of them looks slightly different. So go back and look at those when you look at it under the microscope. So you favor neural here. I agree with you. This is a neural neoplasm. Now, there's probably only about 8 to 10 neural neoplasms that you need to know about in dermatopathology. So
Mhm.
what's the most common one that you see by far?
A neurofibroma, maybe.
Yeah, by far. We see 1,000 neurofibromas for every other type of neural neoplasm, maybe more than that.
Hmm.
Um, so if you just saw this area right over here, I said, well, it kind of looks, that could be a neurofibroma. It's got this sort of mucinous stroma. It's got the cells in here, maybe a little more cellular than usual, but possibly if you just saw this area, it could be a neurofibroma. But then let's look around and see if there's anything else that kind of gives us any kind of clues. And we see some of these structures up here. What are we looking at right here?
Those looked like Antony or like Veracay bodies to me.
Yes, these are Veracay bodies. And what are Veracay bodies? Where do we see Veracay bodies?
Do you mean what uh,
Yeah,
structures are
which kind of neural lesion do we see Veracay bodies in?
in schwannomas?
Yes, there's two types of schwannomas, or neuralomas, are the name for that. There's one that's got the Veracay bodies, and then there's another one that doesn't have the Veracay bodies. Which one's got the Veracay bodies?
The hmm,
There was an Italian um,
oh,
histologist that described these years ago.
the Antony A regions.
Yes, Antony A. And the good news about that is the Veracay rhymes with Antony A. So you can just always remember if there are Veracay bodies in here, well, then it's got to be an Antony A. And here you see the little Veracay bodies. These are the little Schwann cells here and this little acellular, kind of almost fibrotic area in the center of them. And then another zone here. I always like to think that they're sort of like, the Trojan War. You got the Greeks on one side and the Trojans on the other. And here's the field of battle. And they're getting ready to charge across and attack one another.
Mhm.
So that's a Veracay body. And then there's another kind of clue. Now, if you don't see Verrucay bodies, you see a lot of this kind of change here. Well, then it might be an Antony B. They don't really, they're not going to ask you to distinguish between an Antony A and an Antony B unless it's got really classic Verrucay bodies in there. They might sort of expect you to know it in that situation. One other thing that we often see in a schwannoma, I don't know that we're going to see it in this specific one, is you'll see a little nerve twig off to the side of the lesion. Here's another nice zone of some Verrucay bodies here. And so the way that these lesions develop, a way you can think about it, is if you went inside a little nerve twig, you're small enough to go into a nerve twig and then you set off a hand grenade and it exploded, that would be like a neurofibroma because the center of the nerve twig just becomes massively expanded and the Schwann cells and the mucinous stroma are there and you don't really see any Verrucay bodies. You don't really see any pre-existing nerve twig in a neurofibroma. In a schwannoma, it's like if you took that hand grenade and you walked on the outside of the nerve twig and set it off, and then the lesion kind of exploded off of the outer part of the nerve twig. That's what you get with a schwannoma. So neurofibroma, you can sort of think of it as maybe, being something that developed within the nerve, neurofibroma, schwannoma off the side of the nerve twig. Now, we thought this was a shaved biopsy, but now that I look at it more carefully, do we still think it's a shaved biopsy? At low power, we thought this was epidermis, right?
Right, yeah.
And it's not, is it? It's not. So this was not a shaved biopsy. This was a enucleation biopsy, which is the classic situation for these. They present as a cyst or a nodule in the skin. Clinicians never, ever think of these. They always think it's a cyst. And so they do a little cut on it. They pop it out just like they do with the pilar cyst on the scalp. And lo and behold, it comes back as a schwannoma like this. So good. So that's pretty straightforward. They could very well ask you this on the board. It's fair game. It's an easy one to get. And they want to know that you can recognize the difference between a smooth muscle neoplasm, a neural neoplasm, and maybe a fibrohistocytic neoplasm. They're probably not going to get into all the details of the different types of nerve neoplasms, but they very well could ask you something like that. Very good. Good job. Okay, we'll go to this one next.
All right, I can take this one.
Okay.
So this one looks like it was punched out or maybe an enucleation.
Or maybe even an excisional biopsy.
Yeah.
Yeah, good. It's a beautiful biopsy specimen here.
Yes, it's very, I think it's neoplastic, but it's
Okay.
very well circumscribed, relatively symmetric. So I think it's benign.
Yeah, it's got the same architectural features as the last one, doesn't it? This time we've got known skin overlying it. So this again was deep in the dermis. And I totally agree with you. Small, relatively small, symmetrical, well circumscribed, strongly favors benign. So you think this one, as opposed to the last one, is epithelial or non-epithelial this time?
I would say this one is epithelial.
Yes, good. And just the last one, we saw what looked like a very pale, diffuse process, and we get to higher magnification, we saw spindle cells. At low magnification here, we see cells that have got a basophilic quality to them, and then some that have kind of an eosinophilic quality centrally. So these almost look like they're forming some kind of structure here. So yes, epithelium. Now we think of epithelium, the next question is, what kind of epithelium are we dealing with? And so what are some types of epithelium that we have in our skin?
Well, I know it can be like follicular or adnexal.
Good. Yes, you can get like adnexal neoplasms, adnexal epithelium. So yes, follicular, sebaceous, eccrine, apocrine, all of those. Good. What else can you see? There's just a couple of others from an epithelial perspective.
Like just like basal and squamous, that kind of thing.
Basaloid, yes, and squamous. Yeah, that's pretty much it. Exactly. So we're looking at this. What do we think we're dealing with here?
I think this one is follicular.
Good. Yes, follicular. That certainly doesn't look ecrine or apocrine at low magnification. We don't really see any apocrine decapitation secretion. We've got a higher magnification, certainly don't see any of that. Okay, so we think it's probably follicular. Now, there's three parts of the hair follicle, right? Really four, but three major ones. So what are the three parts of the hair follicle, and which part of the follicle do you think this one is recapitulating?
So I know there's like the matrix.
Good. Yes, there's the matrix or the inferior portion of the follicle. So if we're looking over here, for example, there's a hair bulb right here. This is a little telogen follicle. So that's a normal hair follicle. So that's matrical epithelium. Good.
And then there's like the inner and outer root sheath.
Yeah, and those are all kind of part of the lower part of the follicle. So you can think of like the infundibulum, the isthmus, or the kind of germinative area where the um, stem cells like to live in this area right here. And then you get the inferior portion of the follicle where the matrical cells live, and then all those internal root sheath, outer root sheath, all of those portions of the follicle sort of live on the inferior portion of the follicle. So if we're looking at this, do we think this is going to be the top, the middle, or the bottom part of the hair follicle?
I think those darker basaloid cells look kind of like the hair matrix or the
Yeah,
matrical cells.
good. Precisely. These are the lower part of the follicle, the matrical epithelium. That's the rapidly proliferating part of the hair follicle that's producing the hair shaft. Exactly. This isn't the maturing hair shaft. It's actually producing the hair shaft. And so we look here. What am I pointing to right there?
Is that a mitosis?
Yeah. Okay. So are you going to see a couple of mitoses in here? Is that going to make you automatically think it's malignant?
No, I don't think so.
Good. Excellent. Don't fall down that trap, because this is a rapidly proliferating epithelium, and you would expect it to be mitotically active. It should be mitotically active. So yeah, if you see a few scattered mitotic figures in this, even if you see quite a few mitoses, that doesn't mean that it's malignant. So you want to use the architectural features and the other things like that too. Okay, so you've decided this is a benign adnexal neoplasm. It's got matrical differentiation. Does it have anything else in here that helps you with the diagnosis?
Yeah, so those kind of pink amorphous areas have the empty nuclei, the kind of ghost cell appearance.
Yeah, what do we call those cells there?
Ghost cells, shadow cells?
Shadow cells, yeah. I guess you can call them ghost cells. It's getting close to Halloween, so may as well use that term too if you want, I guess. But yes, these are the so-called shadow cells. And so what's the diagnosis?
Pilomatricoma?
Good, pilomatricoma. Very good. Straightforward, classic, beautiful example. It's an easy one. So they might show you this, and that's kind of the good news. You've got the diagnosis. You feel like you're ready to move on to the next question, and lo and behold, you look down and they have this lesion is associated with which of the following conditions? A second order question. So then you start saying, oh no, it wasn't good enough for them that I could recognize the diagnosis and get it right. They want to know now what diseases are associated with pilomatricoma. So
Is
what
it
conditions are you aware of that can be associated with usually multiple pilomatricomas?
is it Gardner syndrome?
It can be seen with Gardner's. Usually patients with Gardner's, they can get pilomatricomas, but they can also just get multiple regular infundibular cysts, and they get desmoid tumors. They obviously get GI cancer, colon cancer, but they can be seen in Gardner's. So yes, that is correct. But there are a couple of other conditions that they might expect you to know.
Myotonic dystrophy?
Yes, yes. Another name for that they used to teach us when we were residents was Friedreich's ataxia, which I think is the same basic disease, but yes, it is associated with neural lesions. And there's one relatively recently described scenario where you get multiple pilomatricomas that it can be associated with. And sometimes the board like to ask relatively recent descriptions. They want to make sure you're kind of current with the literature.
Is it Rubenstein tape?
aware of that one. It's possible. I may not know that. It is possible, but there's glioblastoma multiforme has been
Mm.
associated with multiple pilomatricomas, especially if they're in kind of younger individuals. And that was just recently described, probably in the last 8 to 10 years. And I believe some, dermatologists described it. So whenever, it's something like that that a derm is involved in, beware. They like to ask about that. So just make sure you guys kind of are up to date on some of these relatively newly described associations with relatively banal entities. So just be aware of that. Great. Okay. Beautiful example of this entity.
Okay, I can take this one.
Okay.
I think this is excisional, like down to fat.
Correct.
And this is a neoplastic process. It's
Okay.
large, but it's symmetrical, pretty homogeneous, and relatively well defined. So I
Yeah,
think it's
I agree.
benign.
Based on what we have here, it may go over to this edge, but it seems like they got 90% or more of the lesion out. And if we assume this is representative of the whole thing, which I think it is, it's obviously quite symmetrical. So once again, I think we're dealing with a benign process at low magnification. We can always change our mind and go to higher magnification, but certainly favor benign here.
Agree.
Now, do you think this is going to be epithelial or non-epithelial? This one might get a
That is,
little at low
yeah,
mag.
this I think is tricky. Because like from this power, perhaps you would think epithelioid.
Yeah,
Um,
yeah, yeah. But is it one of the traditional types of epithelium that we see? Like the last we said, follicular, we can see that pretty obviously at low power. What about here?
no, I can't discern like a distinct pattern of
Yeah,
like the
it's
typical
certainly not
epithelium.
squamous epithelium. It's not
Mhm.
follicular. It's not sebaceous. It certainly does. I mean, maybe if we go to higher magnification, we can maybe see some apocrine decapitation secretion in some of the cells. Who knows? But certainly it doesn't look like the traditional classic epithelial differentiation that we see, but it does look like the cells are pretty closely opposed to one another. And it doesn't look like a spindle cell lesion with that fibromucinous loose stroma like we saw in the very first case.
Right.
So if it's an epithelium, it's going to be kind of a different type of epithelium. Good. Okay. But benign. So now let's go to higher magnification, see if we can tell anything more about it.
Right. So as we go in, we can see these kind of like purplish polygonal cells, really rounded up nuclei, um, with a granular purpley pink cytoplasm.
Okay,
Um,
good.
mhm. And then some dense, like intervening collagen. Um,
So it sounds like you probably know the diagnosis.
I was thinking that this looked like a granular cell tumor, or I was also thinking of like a lipidized dermatofibroma, or some like terrible malignancy with granular change.
Okay. Now, why the malignancy?
Um,
See any mitoses or any atypical
no,
cells? No.
no, I just,
Low power, we thought it was benign.
mhm.
So if we change our mind to malignancy, we'd really need to see some features that really just absolutely said, wow, there ain't no way this is benign. So if we saw a lot of mitoses or anaplasia or necrosis on moss, which we don't see any of those. So I think we can stick
Mhm.
with benign. Um, it does look, there's definitely the granular cytology of the cells. I'm glad you recognize that. That's very, very important. Um, lipidized cells usually don't have this kind of pink granular morphology like this. Maybe some of these cells kind of look like they might be kind of lipidized in this area, but and if you see a dermatofibroma, you're usually going to see some cirophages in there and some spindle cells in addition to the histiocytes. So um, I'm glad that your number one diagnosis was granular cell tumor. But yeah, it's always good to have a differential diagnosis, and presumably you wouldn't have chosen those others if they would have been thrown in there as choices. You felt pretty confident that this was a granular cell tumor, correct?
I did.
Good. Okay. Good. So tell us about a granular cell tumor. What is
Um,
the origin of these cells, or what is the differentiation of these cells?
they're like Schwannian differentiation.
Good. And it is a type of epithelium in a way. This is what we call one of the neurocrestopathies from the neural crest, which is a type of neuroectodermal epithelium. So when the cells kind of differentiate more toward the spindle cell morphology, we sort of say, well, I don't know which epithelium anymore. But if they have these kind of morphology, we say, well, it's kind of a neural crest type of epithelium. So it is quasi-epithelium, like you said, at low magnification. But it is a neural neoplasm, and it is Schwannian. So if you wanted to stain this to prove that that was the case, what kind of marker might you put on it?
You could stain S100.
Good. And is there any other marker that you might use to kind of prove that these are granules inside these cells here?
For the granules, like a PAS stain.
Yeah, good. PAS stain will highlight the granules. What are the granules?
They're lysosomes.
Yeah, they're lysosomes. Basically, what they've gone in is engulfed this deficient myelin that's being formed by these cells. So these aren't normal Schwann cells. They're trying to make myelin, and instead of making myelin, they just kind of got filled up with this sort of degenerated myelin in process, never made it, and the lysosomes come in and engulf it, and then they fill up with these granular cells, the granules like this. So it's a Schwannian lesion. Years ago, we used to think this was a muscle lesion. It used to be called granular cell myoblastoma because they kind of look like muscle cells here. And what's another location that we see these very commonly? This one isn't that location here, but what's a common location where we see this lesion?
You can see it on the tongue.
Yeah, the tongue. And that's why years ago they used to think it was a myoblastoma because obviously the tongue's got a lot of muscle in there, and it's often seen in dark-skinned patients, African Americans, for example. It's a very common lesion on the tongue in that setting. So just make sure that you know that. They might even show you a clinical photo of a lesion on the tongue. And there's one last thing that we often see that we don't see here. That's sort of a pitfall in the diagnosis if you get a shaved biopsy of a granular cell tumor.
You can see like pseudoepitheliomatous change
Yeah,
that looks like squamous.
so good. I've actually made that mistake once or twice in my career too, where I got a superficial shaved biopsy and it looked like a squamous cell that was overlying a granular cell tumor. So you got to make sure that you get deep enough and get into the granular cells. If you just get like here and you've got marked pseudocarcinoma hyperplasia, you're going to miss the diagnosis in many cases. And then the last teaching point is that granular cell morphology is not specific for granular cell tumor. We sometimes see granular cell leiomyomas, see granular cell atypical fibrous xanthomas. You can see granular cell differentiation in fibrous papule. So it's basically can be a reaction pattern also, in addition to being seen in granular cell tumor itself. These are almost always benign. If they're going to be malignant, they really need to be very asymmetrical, have a lot of mitoses and whatnot. They can be pretty big and extend pretty deep, but they're still benign and they almost never turn into malignancy. Okay, good. Okay.
So yeah, I can go ahead and take this one.
Okay.
So I guess the first thing when we take a look here, this seems like to be a punch, potentially.
Pretty big for a punch. I mean,
You call it an excision, therefore?
I think it's probably another excisional
Excision.
biopsy. Cut the whole thing out. They may have already had a previous biopsy, and then they said, well, let's go back and excise it. And they kind of failed. And then we already got it all out. So they got more work to do here.
Yeah. So I mean, yeah. So we'll consider this as an excision. Kind of the big features associated with this particular lesion. It has to do really with the more of the deeper dermis or that entrapment of what's going on in there.
So something's going on here, isn't it? That's not
Yes,
normal.
that's correct.
This is pretty normal over here. This
Yeah,
is
seems like
normal
the
up here. We've got this thing going on down here.
so if we zoom in into more of a higher power in this particular slide, what I
Before we
initially
do that, we're going to ask ourselves whether we think it's going to be, neoplastic or inflammatory,
this
or they like
this
benign or malignant, or
potentially looks like more of a neoplastic process.
Yes,
Uh-huh.
I agree with you. Certainly doesn't look inflammatory. I mean, something's going on here with all these dark cells here. They don't look like lymphocytes or histiocytes or anything like that. So I think there's epithelial cells here.
Mhm.
Um, so we think it's a neoplasm epithelial. Can we tell whether it's benign or malignant?
I was just based on kind of the symmetry and the organization. I was feeling more of this as more of a malignancy, but
Okay. Yeah, I agree. It could very well be malignant. Now, it does have a fairly well circumscribed morphology up here, but then it goes to the base and what's going on over here? This seems like that
Mhm.
might be a sign of poor circumscription. So we've got some conflicting criteria. And sometimes if you see something that looks kind of conflicting like that, it might be malignant, but it might be a very low grade biologic malignancy. For example, like a basal cell. Sometimes you'll see just a
Mhm.
nice nodular basal cell that looks fairly small and symmetrical. That's a cancer, but it's not going to spread and kill the patient like malignant melanoma, or like a poorly
Right.
differentiated, Merkel or something like that. So it might be malignant, but it may be low grade. Okay, good. Anything else you can tell at low power before we go to higher magnification that you can see?
Not as much as you already mentioned. I mean, like I said, the epidermis and the superficial dermis look very benign in nature. So it's really kind of what's inside that entrapment that's
Okay, good.
big features
You've
here.
got, you've got these cells over here, but is there anything else notice here? Don't overthink it. Just sort of dial back and say, what kind of color, what do
So
you
yeah,
see for
it,
describing
it
this to a 5-year-old kid, for example?
yeah, I mean, initially they look like epithelial cells to me. So like these
They
epithelioid
do.
cells kind of nested together.
They're nested together. And then what about this kind of stuff over here?
It looked more like mucin deposition there.
Good. Yeah, it's white.
Hmm.
It's kind of got a whitish, grayish color, so it's got some pallor to it. And then it's got these small aggregations of cells here that seem to be floating in that at low
Yes.
power. So that's helpful if you can recognize that at low power. Now we're going to higher magnification. And this lesion is kind of interesting because when you look at the individual cells, you may not see that many pleomorphic, bizarre cells or in mitosis or anything here.
Yeah, it's just some mild pleomorphism there, but nothing
Minimal though,
significant.
isn't it? Minimal. Here's maybe a large nucleus here and
Hmm.
a couple up here, but very few mitotic figures. Less mitoses here than in the Pilomatricoma, which was a totally
Yeah.
different.
And I don't know
So
if you would consider them a little bit enlarged or not, but
some of the cells are enlarged. I totally agree. Can you tell about the differentiation of these cells?
mm, I
And
mean, if
this
you guys,
is somewhat of a slightly controversial issue in dermatopathology, but do you see these cells? Almost look like they're kind of getting a little bit of apocrine decapitation secretion here. And
okay.
some people say that my old mentor, Dr. Ackerman, used to claim that every lesion just about that was thought to be ecrine was really apocrine because you could always find one or two cells that looked like they were doing decapitation secretion. I don't know what that means that it's ecrine or apocrine, but certainly it kind of puts it in the adnexal ecrine apocrine category,
Uh-huh.
possibly. So what do you think the diagnosis is here?
So I was initially thinking that this may be a mucinous carcinoma.
Yeah, it is a mucinous carcinoma. Not a bad name. So we
Hmm.
got a lot of mucin in it. And it's got these epithelial cells here that maybe they got some pleomorphic nuclei. But this is a diagnosis made primarily on the basis of architecture, because if you look at the cytology, you're not going to say this is really super atypical. And these lesions tend to behave in a very low-grade fashion, kind of like a basal cell carcinoma. Here's a nice ductal differentiation of the lesion right here. So there's a duct. So it makes sense that these would behave in a fairly low-grade fashion. It's
Hmm.
got a relatively, benign appearing architecture. It doesn't really have a lot of pleomorphism and striking atypicality of the cells, but it is a cancer. And if you leave it alone long enough, it can gradually go deep and get into the eye and get into the caruncle. It's seen in around the eye area very commonly. And so you want to get rid of these. Okay, so that's good. Now, board expects you to get that pretty quickly. They might ask you a couple of questions. Is there
Uh-huh.
any of subtype of this lesion that's been relatively recently described that can look very similar to this, but tends to be more solid than this cells floating freely in this sea of mucin here.
A subtype? I mean, are you considering something like a endocrine producing sweat gland
There you go.
carcinoma?
Yes. Good. Mucin producing endocrine sweat gland carcinoma. That's the other name, and that's a fairly recently described variant of this. I tend to think of those as probably being on a spectrum of this.
Mm-hmm.
So in some cases you get it where it looks like this. In other cases you get still quite a bit of mucin, but more of a solid component to it. And if you stain that, when it says, what's the neuroendocrine part of that? If you stain that lesion, what are you staining it for?
Let's see.
The endocrine quote part of that, the endocrine that they talk about. What is the endocrine marker that you stain that lesion for that highlights these cells, if that is what it is?
It's not a CK7, is it?
No, now we'll talk about that in a moment too, though. No, it actually stains with things like neuron-specific enolase and INSM1 and synaptophysin because it's got a neuroendocrine kind of component to it. It's not Merkel. It doesn't behave like a Merkel cell, but it does stain like that neuroendocrine kind of component. So just make sure you know that there is this endocrine mucin producing, and the endocrine part is neuroendocrine staining. Okay. So that just remember that it actually will stain that way. And it can look kind of like this. Now, you mentioned CK7.
Yes.
Now, what if you stained this and it was CK7 positive? First of all, I'm going to say just right now, that's not going to rule this disease out necessarily. But if you did get CK positivity, what disease would you worry about here that you need to make sure the patient didn't have? And then what if it is CK20 that was positive?
Would you be concerned for a underlying metastasis from another site?
Good. Yes, good. If it's CK7, maybe a mucinous breast carcinoma that spread to this area. If it's CK20, you might worry about a mucinous GI below the diaphragm that spread to the skin and causes. So anytime you see this, you're obligated to make 100% sure the patient doesn't have an underlying mucinous carcinoma that spread to the area. This one did not have, and this one also didn't stain positively for the neuroendocrine marker. So this was just a classic so-called mucinous carcinoma of eccrine glands. But as you saw, there were cells that almost looked kind of apocrine in some areas. So, but it is called mucinous carcinoma of eccrine glands. And it is low grade. I mean, these lesions generally tend to behave in a low grade fashion. You just need to, totally remove them, and they usually don't cause any more harm than that. Okay, good. That's the kind of stuff that they'll expect you to know on the board examination. Okay, this is a good one here.
Yeah, I'll take this one. So this is a punch.
Good.
And looks like thick dermis, maybe trunk extremities.
Good.
And this looks inflammatory.
Good.
So it looks like the inflammation is right up close to the DJ. So maybe some interface dermatitis or perivascular, and then there's a blister.
Perivascular, but it's interface. I completely agree with you on that. Now, there's two types of interface, right?
Like lichenoid kind.
Lichenoid, and what's the other one?
Vacuolar.
Good, good. Vacuolar and lichenoid. And which of the two are we dealing with here?
This almost looks, it kind of looks like it's in a lichenoid band.
Close.
Okay, it's vacuolar.
Yeah, see the little vacuoles
Yeah.
here?
Okay.
This is vacuolar interface
Okay.
dermatitis. And what have we got here? What am I pointing to right in these areas here?
Right there.
Yes.
It's like dyskeratotic cells.
Good. Good. Dyskeratotic keratinocytes. Excellent. Now, the good news is Yeah, you've recognized this now. Excellent. Very good. So they're not going to ask you to look at this and instantly make a diagnosis. Okay, that's highly unlikely unless it has some really characteristic features that were classic for some disease. But so you've identified it as an interface dermatitis. Now, what's the differential diagnosis of interface dermatitis vacuolar type with dyskeratotic keratinocytes? What are some of the things that you have to think about to hone the diagnosis a little bit more closely? What's the most common thing that we see in dermatology with this pattern?
With interface,
Vacuolar interface
dermatitis,
dermatitis.
like eczema or.
Well, that doesn't usually give you a vacuolar
Okay.
interface dermatitis, though, right? That
Okay.
gives you more spongiotic dermatitis. But what's
Okay.
the most common vacuolar interface dermatitis with dyskeratotic keratinocytes like we're looking at here? The most
Erythema
common.
multiforme?
Well, that
Not,
is,
not
you
the most
can't
common.
see that. That does give you that pattern, but is that
Okay.
the most common thing?
Like lichen planus. I mean, I guess that's
That's lichenoid.
lichenoid. Yeah. Hmm.
You know it. You're just not thinking about it. What's the average age of most of the patients that come to see us in our clinics, usually with skin inflammatory conditions, other than Peds Derm Clinic?
Inflammatory, like
Yeah, what are the, so you see an
40s,
adult population
20s to
that
40s.
come
I
in
don't
with
know.
a widespread dermatitis. Your differential is going to be maybe atopic, contact rhinommular, or what else do we commonly think about in an adult population, senior citizens?
Senior citizens.
Senior citizens are always taking medications.
Okay, so drug reaction.
Drug eruption. So this is actually one of the most common patterns of a drug eruption. An interface dermatitis like this with dyskeratotic keratinocytes, they got this widespread, scaly, sometimes more biliform eruption. You biopsy it, and it looks like this. It looks very much like this. So now they're not going to show you this and say, what's the diagnosis? But they might show you this and put 3 or 4 things down in differential diagnosis and expect you to kind of figure it out. Now, do you have to see EOs? You know the answer to that already. Do you have to see EOs in a drug eruption?
No.
No, you don't. And in fact, I'd say more commonly than not, we don't see them. If you do see them, it's great. So let's say you're worried about the differential, say, between, maybe an unusual form of lupus and a drug eruption, because both of those can give you interface dermatitis with vacuolar alteration. If you see EOs, that favors drug, but it doesn't rule out like drug-induced lupus, for example. If it, and here's another feature of this case. Notice this basal cell layer here. It kind of looks like there's squamatization of the basal cell layer. Do you see that? It almost looks like the top of the epidermis. It doesn't really look like a nice basal cell here, basaloid layer. That's very commonly seen when patients are taking chemotherapy drugs. So it's called squamatization of the basal cell layer, and that's patients they're on some type of toxic chemotherapeutic agent. They'll get this pattern a lot of times. Now, I don't know that they're going to ask you that either, but I would just, at least that. You've heard of it. Now, if this were lupus, you might expect to see more mucin. You probably wouldn't see this kind of change here. You can get parakeratosis with crusting like this. Other items that can give you this sometimes, pityriasis lichenoides. If you see eosinophils, it's almost never pityriasis lichenoides. So it virtually never gets EOs. So if you see eosinophils and you think it's pityriasis lichenoides, you can just pretty much rule that out. It's not that. But this is an example of an interface drug eruption, and just, interface dermatitis is probably, it's one of the most common patterns we see with drug hypersensitivity. You get spongiotic, psoriasiform, all sorts of reactions can occur. Drugs can do just about anything, but interface dermatitis is one of the more common patterns. And this was maybe due to a chemotherapeutic agent. Okay, we have 2 biopsies here in this case.
Good morning. I can take this one.
Okay.
So we have here probably what's a pair of 3 millimeter punches, and
Okay.
we can see from 1,000 feet that one of them is going to be vertically sectioned, the other one's horizontal section. So we're probably examining an alopecia here. So in
Actually, that's not it there.
it's
Let
a
me go back.
6'2" and 6'1".
Yeah, this one, I did the wrong one. Yeah, good.
Yeah.
Which of these two do you like better in this case to examine?
I actually I prefer 6'1", but I think 6'2" is classically what's supposed to be used for the diagnosis. But the
Yeah, and usually I like the vertical most of the time. But here you've only got just one follicle really that's kind of still got some changes down here. These two are in telogen at this point. But this is one of the nice reasons that we do these vertical and horizontal sections, because here we're like doing a cross section. We're getting, look how many follicles we're looking at. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We're looking at a lot of follicles here at the lower part of the follicular epithelium. So we can see more changes in this one rather than in the other one this time. So often the other one is diagnostic, but I think you get better changes at this time in this one.
mm,
So you're right, it is an alopecia. So what's your approach when you're looking at alopecia biopsy?
the first one is to check to see if there is indeed alopecia. So count the hair follicles, and then to go
Okay.
into
And
inflammatory
quickly tell
versus
that
non.
over here, right?
Yeah,
So this is on the scalp, and how many follicles should we see rooted down in the subcutaneous fat?
on the order
Well,
of 6 to 8 probably.
yeah, 8 to 10, 6 to 8, yeah, for sure. How many have we got here?
I see maybe 2.
Yeah, maybe not, maybe 0. I mean, this guy's probably the only one that's got a little bit of stuff left in the fat. So yeah, this could be a striking alopecia here. Okay, good. What's the next step?
So inflammatory versus non-inflammatory.
Good. And then the next step.
Scarring versus non-scarring.
Good. And what's the subtype of that you look at?
Oh, that's an excellent question. Let me think.
I try not to ask stupid questions, but every now and then I do. So, well, there's two ways the scarring develops in a hair follicle,
Is
interestingly
it
enough.
characterizing the inflammatory infiltrate as either lymphocytic versus mixed? Or
Well, that's an important finding also. You're correct about that. But there's two ways scarring occurs in an alopecia, if it is scarring alopecia. One, it can be kind of like a rifle shot, like sniper. It can hit just the actual follicles. So it can be perifollicular, it can just hit the follicles themselves and leave everything between the follicles alone. And the other way is when it's sort of like an invasion, where something comes in and just trashes everything. It's follicles, dermis, there's diffuse scarring. So, for example, like in folliculitis decalvans, that's basically just like, Russia going into Ukraine. It's just, scorched earth. It's destroying everything. Okay. Whereas if it's sniper shots, it's blasting the individual follicles and leaving everything else alone. That's like in planopilaris, for example. More common with discoid lupus, although you can get interstitial inflammation with lupus, you get involved with the dermis and the epidermis between the follicles of lupus. So you look for, is the scar just hitting the follicle alone, or is it diffusely involving the dermis? And if it's involving the follicle, where is it in the follicle? Is it at the infundibulum and the isthmus, where we see lichen planus, for example? Is it like near the base of the follicle? We see kind of this onion skin kind of rimming around it, where we see like in chronic traction alopecia, which doesn't just hit only the infundibulum. So there's a pattern to the scarring also that can give you clues to the diagnosis. Good. So did you think this was scar or non-scar?
non-scar.
Non-scar. Okay, good. So what did you notice about this in this one, for example?
Well, on this slide, we're going to
Kind of
see.
fuzzy. I'm sorry, I apologize for it's nice blurry, but you can see. Do you notice these follicles here? What do you notice about them?
There's a couple things. One is they're in telogen phase.
Good, good. All of them are in the same stage of involution. In fact, I think they're actually catagen and telogen. They're like, these things have all been like, they were sitting there normally growing, everything's fine, and suddenly, boom, something caused them to shift all at once into a catagen and telogen phase. And what else did you notice about this?
They do have it's easier to appreciate, I think, on the previous slide, but they have a peribulbar infiltrate.
They do, yeah, and yeah, I apologize for that one. There's a little bit of peribulbar inflammation over here. There's not much even in this, but there's a tiny bit here, like you noticed. So what's the diagnosis?
Alopecia areata.
Alopecia areata. Good, excellent. There's nothing else in dermatopathology that will give you synchronization of all of the follicles like this than AA. So when everything gets hit, and especially if you see multiple follicles in catagen at the same time, that really doesn't happen in anything other than that. Even in patients taking chemotherapy, they don't hit all their follicles. If you see somebody who's got chemotherapy, they don't lose every single, their hair becomes kind of like a diffuse alopecia, but it doesn't get every single hair follicle. They still have some hair there. Alopecia areata will turn into a billiard ball. And the individual patches of alopecia areata are totally devoid of hair. And then you'll see the exclamation point hairs. You'll see the white hairs, which are more resistant to the inflammatory reaction. So you can make the diagnosis here even without any peribulbar infiltrate. Even though it's out of focus and fuzzy, we can still make the diagnosis just based on the fact that it's all synchronized like that. So good, very, very good. So this is, they very well could show you something like this on the exam. So you'll probably encounter alopecia areata at some point. Don't know if they'll show you two state follicles like that, but they might. Okay, this one's a little less. This is a good example of this entity.
I can take this one.
Okay.
So it looks like an excision, like deeper tissue, looks from like afar kind of disorganized, looks like a neoplastic process.
Okay.
But then we do see these like more hypo and then more hypercellular areas. The like hypocellulars have these like blue kind of almost like pinkish areas. They almost appear kind of cartilaginous. But
Okay, so once again, this might have been an enucleation type procedure. They might have thought this was a cyst or something, right? Because they overlying epidermis, like that case of the Pilomatricoma, had a nice normal skin overlying it, or the Mucinous Carcinoma had normal skin overlying it. Here we've just got something kind of deep. So this is more like the Schwannoma a little bit, right? They might have said, there's something deep to the skin here. Let's go ahead and cut this thing out of here.
yes.
So they basically enucleated it. And if it kind of comes out like a little lump like this, does that favor benign or malignant?
Favors benign.
It does favor benign. Good. And you said this maybe looked kind of cartilaginous. So you're thinking it's probably non-epithelial, right? Because cartilage is an epithelium.
Right. It like appears cartilaginous. I don't think it is cartilage, but
Okay. So we have our three main types of non-epithelial differentiation. And some of these over here do have kind of a spindle type morphology to them, don't they?
yeah, they look a little bit, but I don't think it's a neural process.
I agree. Does this have a fibromucinous stroma?
Pardon me. Sorry, I didn't hear that.
Does this have like that mucinous stroma like that first case that we saw?
No, not really.
No. It's got more of a pink eosinophilic stroma here. Good. Very good. And then what's this material?
All of that, it looks like calcium deposition.
Good. Calcium. Okay, that may or may not kind of be important. But then let's take a look at this area up here. Now, this is where it kind of gets a little esoteric, and you may not know what this is, or if you had a chance to read about it and study about it, you might have learned about it, which is fine. And I'm doubtful you're going to encounter this on the board examination, but if you do, you'll be prepared for it.
Yeah,
so a little bluish and grayish, and it's kind of got some mucin material in here, most likely. It's even possible that could be some cartilaginous metaplasia and evolution right there. But it's got this stroma, and then it's got this bluish stroma, and then it's got these spindle cells in it, and then it's got this dystrophic calcification.
So are you asking like what it is?
You're more than welcome to volunteer and answer. Know what it is.
Yeah, so I think with the biphasic like hypocellular and hypercellular areas. I think it's a myofibroma.
Yes, this is a juvenile, or it doesn't have to be juvenile, but in this case, it was a juvenile myofibroma. And this is a relatively rare entity. Probably the key to the diagnosis is recognizing this. First of all, this is one of those see one, remember it, never forget it kind of things. But you do very classically get this amorphous bluish gray mucinous-like material, which is kind of funny to get in a lesion with muscle differentiation. So this really is a classic smooth muscle. It's myofibromatous differentiation. So it's kind of got a combination of fibroblastic and histiocytic differentiation plus smooth muscle cells. And sometimes these cells also can get even a hemangiopericytoma-like component to these. So these lesions are actually often called myofibroma pericytoma, hemangiopericytoma. So this vascular component here is often considered part of it. The calcification is, don't have to see that. You can see it, but you don't have to see it. And it's just a relatively rare entity, but at least now you've kind of seen one. And this is pretty prototypical for what they look like.
Mm-hmm.
Where do we see these? What's the setting that we see these most commonly?
In kids, it can be like part of that infantile myofibromatosis syndrome. They can
That's
often be on the
right.
head, like on the scalp, more common in females.
Yeah, that can be some of the trunk and extremities too. You biopsy one of these. They're just kind of these kind of firm nodules. Sometimes they're a little bit tender, but usually there's asymptomatic. These, and when you see a kid that's got these sort of relatively large lesions, obviously you get kind of concerned about it. Could it be like a neuroblastoma or Wilms tumor? One of these horrible blue cell tumors. And then you biopsy and it sees this, and you kind of, you know, say, whoo, it's not anything really super to worry about. Although these things can be multiple, and they can actually sometimes involve other structures inside the body. But in general, these things are benign and they're not malignant or anything like that.
Mm-hmm.
Okay, maybe we have time for one last one that's pretty straightforward.
I'll do this one. This looks like a punch or nucleation of something. I felt like this one you could tell the location because of the thick stratum corneum and the prominent granular. So it seems like an acral location. And then we have a neoplasm, non-epithelial on higher magnification. I was leaning like fibrohistiocytic. Overall, it's like a small, well circumscribed and over, like symmetrical lesion. There's pink fibrin, histiocytes, and then I felt like some of the cells were like palisading or spindled.
Yeah, what's this pattern look like? This is an interesting case because it's kind of got two things going on. What's this right here?
The bluish stuff, I think it's might be mucin.
This is actually a splinter.
Oh, okay, foreign body. Okay.
Foreign body. But if you look at this, does this look like a classic foreign body reaction here?
No.
No. Doesn't this look like a palisaded granulomatous dermatitis? So here are the histiocytes. Mucin, mostly fibrin in the center of the palisade.
Yes.
So what disease gives you fibrin in the center of the palisaded granulomatous dermatitis? I'm not sure what that splinter is doing there.
Maybe a rheumatoid nodule.
Rheumatoid nodule. Rheumatoid nodule is what, again, I don't know, maybe the person had rheumatoid arthritis, had a rheumatoid nodule and got an injury and got a splinter in there. I mean, I have a hard time believing this entire thing was induced by a splinter, but there's no question there's a splinter here. And so maybe it's just a weird rheumatoid nodule-like reaction to a splinter, but I have a feeling the person had known rheumatoid arthritis, and then this is just a coincidental finding. But this is a nice example of palisaded granulomatous dermatitis with fibrin in the center of the palisade, which is what you're supposed to see in a rheumatoid nodule. Now, you can also see this sometimes in subcutaneous GA. You'll often get more mucin there, but sometimes you can actually see some fibrin in that as well. But this is a beautiful example of palisaded granulomatous dermatitis. So just make sure you know the differential diagnosis: fibrin, rheumatoid nodule, mucin, GA, degenerated collagen, and more of a layer cake diffuse pattern with necrobiosis lipoidica. Okay, very good. And we will, we didn't finish all of these today, but we got through most of them. And so maybe we'll include a couple of those that we didn't cover this week the next time we meet up. Well, thank you guys for attending this morning, and we'll see you next month.